Good, sir, good, good.
बंगाल के अंदर विरोधियों की आवाज को कुचल देना, हिंसा और हत्याओं से डराने का प्रयास करना कम्युनिस्ट शासन में, और अब उससे बढ़ चढ़कर तृणमूल कांग्रेस के शासन में हुआ है। भारतीय जनता पार्टी के कार्यकर्ता अदालत के सामने गए हैं। वीडियोग्राफी
एक तो चलता है रेडियो।
Dr. Nitish sir, shall we start, sir? Hello, Nitish sir.
चलो आगे कितना चला?
Yeah. Hello, Dr. Nitish sir.
Hello.
Sir, hello. Yes, sir. You can start, sir. Now.
Yeah,
Everybody
please.
in the boat.
So you are going to start things, Dr. Grover. With your permission, can we start?
Yes, so sure, sir, sure. We are waiting to hear from you. Do it.
So who is from Sipla side?
Yeah, sir. I am there, sir. ABM, sir. Karnal, sir.
Yeah, Colonel, please start.
Yeah, sir. Good evening to all the doctors for coming on a short notice for this expert forum meet, sir. Today we are discussing with Dr. Nitish, who is discussing about the MRA in heart failure, and study the discussion, and also there is a case-based discussion and so Doctor, over to you to start with.
So your voice was breaking. I hope my voice is clear to you, all of you.
Yes, sir.
Yeah,
Yes, sir.
it's very clear.
Yeah. So we all know that heart failure is quite prevalent, or not only in India but all over the world. And we know that we have different medications to treat our patients to improve the prognosis and their quality of life. We have different pharmacological agents as well as certain therapies which are going to benefit our patients. And among all, we all know that of late, ARNI, previously we were using ACE inhibitors, ARBs, beta blockers, and of late SGLT2 inhibitors, beta blockers, which were used to be considered as contraindications in past, but nowadays it has become a class 1 indication to use beta blockers. And we all know that MRAs, because we know that ACE or these things which leads to chronic inflammatory process, chronic inflammation in the heart, leading to damage of myocytes, severe dysfunction, which is going to be further increased if aldosterone axis remains activated. That is the reason MRAs has become a class 1 indication to treat patients of HFrEF. HFrEF is heart failure with reduced ejection fraction. But we have certain constraint, and the major thing which could be is hyperkalemia, hypotension. So what are the different aspects of use of MRAs in patients of heart failure. We all know that quite prevalent is the heart disease and heart failure, ischemic, non-ischemic, and as the age progresses, the chances of having heart failure, heart dysfunction increases. And it has reached to 10% if we see patients, those who are above 70 years. So that is the reason, as we are having our population which is elderly population, because of good treatment of ischemic heart disease, that is the another reason why we are having more and more people who are having heart dysfunction, heart failure patients, and incidence and prevalence is increasing day by day. So to start with, I would like to have a opinion of the panel that how much is the percentage of patients who reaches to us in different class 2, 3, 4, because this is the major thing, because our all treatment depends on how we treat our patients. They are in class 2, class 3, class 4. So to start with, I would request Dr. Grover, that what percentage of patients do you really have in your practice that who are presenting to you as class 2, class 3, or class 4?
Though most of these patients go to you as cardiologists, but as physicians also, patients come to us. Most of the patients, when reach the hospital, they are already in class 3 or 4. We hardly see patients of class 1 or 2, and this is from their physicians, and breathlessness is ignored by the patients as well as the treating family physicians, I must say, and take it very seriously.
So, Dr. Parminder, since you are patient primarily dealing with the cardiac patients, so do you really see a lot of patients though presented to you with class 3 or 2 also, or the patient directly landed up to class 4? Because that makes a whole difference how you treat your patients.
No, Dr. Garg, good evening to everybody.
Yeah,
now, in fact, most of the times, the type of the patients I'm receiving, they are in fact class 2 to class 3, but sometimes, of course, patients are do land with the acutely decompensated heart failure. But on an average, in fact, in my hospital, once I'm doing the cardiac examination with those patients who are coming with a symptom of shortness of breath or but a good number of times this comes as a surprise when you do the echocardiography that the patient is having ejection fraction that is mildly reduced as MR, EF, or reduced ejection fraction, HFRF, and in fact, most of the time these patients, they have ejection fraction somewhere around 40%, 35%, 25%, and they are symptomatic. On an average, I in fact diagnose between 4 to 6 patients in a week, or sometimes 2 to 4 in a week. That is the percentage. In fact, I can say on an average in my hospital. And mostly the patients, they do present with the symptoms like shortness of breath, or it's a kind of anginal symptoms like constriction, and these are or the fatigue or the generalized weakness. And sometimes the symptoms may be depending on the patients are having valvular heart disease or some other problem cropping up as the heart failure. That may be syncope or pre-syncope or something like that. So in fact, the patients do present with the in class 2 or class 3, and these are the most of the time the symptoms are like that.
If I take my practice, because the thing is, we are getting a lot of referral patients. Those patients who are directly presenting to us with the routine evaluation of heart, because then now there is a lot of awareness that you should get your heart checkup regularly, especially after 40 years, even with mild symptoms. People are presenting to us with class 2 to 3 symptoms, and there's certain chunk of patients, those who are coming to us for clearance of surgery, and in those patients we also can diagnose class 2 or 3, even they are class 1 patients sometimes. And patients those who are referred, as we are having a tertiary, we are running a tertiary center, so a lot of patients they are referred to as in class 4 frank pulmonary edema. And these patients are, if I say referred patients, they are mostly 70 to 80% of the heart failure patients, they are in class 4. But we can very well pick up our patients in class 2, class 1, because if we diagnose early, the treatment would be much better. So, Dr. Rajesh, what is your take on this?
According to my practice, I have class 2. Are you listening me?
Yeah. Your voice is clear. You can go ahead.
According to my practice, I receive usually class 2 patients which have got the mild symptoms in the OPD basis, and class 3 patients are mostly got admissions, and class 4 patients we used to refer to higher centers. And according to me, I am doing the color Dopplers. We got admissions for 35% to 40% ejection fractions, and with preserved ejection fraction more than 50%. If symptoms are there, then most of the patient get treatment in the OPD basis, and most of the patient with heart failure with preserved ejection fraction borderline, with the ejection fraction of 41 to 49%, they still got treatment as OPD basis. So this is my opinion.
So, Dr. Vikasdeep, so what are you there, please? Dr. Vikasdeep?
I don't think Vikas is there.
Yeah. So, what are the diagnostic prognostic tool for heart failure patients do you use for whenever a patient who presented to us with symptoms and signs of heart failure?
You're asking.
Yeah,
asking
Dr.
Vikas,
Vikasdeep, yeah.
No. Dr. Grover is saying that possibly he's not there.
No, Dr. Vikasdeep is, I can see his video. Dr. Vikas?
There's one picture with the person is standing with his wife. That
You are mute.
I don't
Dr.
think
Vikas, you are
Vikas
mute.
is there.
Dr. Vikas, you are mute.
That is Arvind. Vikasdeep's phone is muted. Yes, you're right.
He's on iPhone and his video was also coming.
I think you proceed further. When he joins, then we can ask him.
Yeah. So Dr. Grover, what do you say? What are the different tests you use?
When we are suspecting heart failure, patient is coming with the symptoms of heart failure.
Haan
The first thing we wish to do is the ECG and the echo and X-ray chest. Then certain blood tests are also done to a certain whether patient is in heart failure or not. So after this, we will evaluate whether he is in which stage of the heart failure and when to be started. Echo is the most important tool for diagnosing heart failure. Of course, the markers are also required to see the extent, to see the degree of heart failure.
Okay.
Probe and
Yeah. So sorry,
No
Basically,
problem.
for
So pro-BNP and other things, all the markers we usually do to evaluate. But first we do the echo.
Dr. Parminder, what is your take? Because you are diagnosing a lot of heart failure patients, those who are directly presenting to you. So, what would be your first choice of investigations, and then for prognostication, what do you say about all this?
As Dr. Garg, we know that the heart failure is a kind of a protein manifestation starting from the simply angina, the shortness of breath, and all like that. The things, the gold standard in my clinical practice, in fact, that is the echocardiography. And most of the time, I pick up my patients based on this investigation, and I grade the patients accordingly. In what type of the ejection fraction, what is in fact the ejection fraction is, because I'm not really doing anything cardiac cath or anything like that to investigate the patients to investigate patient further. In fact, my practice is based entirely on echocardiography, and accordingly I grade my patient like that, where the ejection fraction is more than 40%, or somewhere less than 40%, or what is the electrocardiographic abnormality? Is it a wide QRS? Is there any valvular abnormality? Or is there any kind of a restrictive abnormality? Or some pericardial or what? All these things, I think, simply looking at the things that it's simple having a glance at the echocardiography that gives you that the picture emerges that what type of situation that you're dealing with. You also look at the IVC, you also look at the loaded veins and all like that. You also look at the pleural sacs, and that I think all these things give you enough information that what exactly is the quantum of the disease that you're dealing with, or in fact, is it a kind of a compensated state of the patient, or it's a kind of a decompensated. And depending on that, if the patient is decompensated, you hardly need to explain anything to you. Simply state of it, go ahead with all these things and further investigation that you do have based on academic interest and all like that, and definitely to have a kind of a supportive you to have more information regarding what exactly the renal profile, what exactly the liver dysfunction, what exactly is there any kind of how much is the urinary abnormality. All these things, I think, is a kind of a state which is in fact a systemic disease. It's hardly to do something restricted to the heart. In fact, I think investigations are based on that. And if it is a compensated state, definitely you have to do a lot of hard work to explain it on to the patient that it's a kind of a situation that is a progressive disease. And the patient is going to be symptomatic of the problem. What you are seeing today, the patient may not be aware of that. At that time, you have to put in little hard work to explain it on to the patient, because there are all these things we are, as we will be discussing the things further, we will be definitely talking about all that matters. In fact, the good diagnostics, if the diagnostic is weak, definitely you're going to miss the train, and your patient is going to land in the soup in the future time. And but if your diagnostic is strong, you have done your homework well. It's a valvular problem, non-valvular problem, cardiomyopathic problem, ischemic problem. It's a kind of the restriction problem, or the pericardial problem, or it's a kind of so all these things. Having a glance at the echocardiography, they give you all the information. If it's a wall motion abnormality, globally weak LV, or say kind of a longitude LV, or say kind of a concentric kind of hypertrophy that is making the relaxation difficult. So all these things, they with the better echocardiography machines and equipments and all, you can have enough information based regarding how much diastolic dysfunction is there, because most of the time you've got a number of patients, they are having both systolic as well as diastolic dysfunction. So at that time you have to be really doing a little bit more, in fact, peeping into the situation really more closely to have a kind of abnormality what the patient is having at the time. I think while Dr. Grover has already said that there are beautiful markers which are available, but a good number of times these markers are absolutely not doing much. In fact, if you are doing a good echocardiography, you are having a good grip on that. That is, I think, a beautiful tool in the hands of a physician, in the hands of a clinician who's doing his cardiology work. And I think you have not to run to the cardiocath or any other investigation. That will be more of scientific or more of academic interest that you may be really doing at the time. But this is what I in fact might take on this particular diagnostics.
So we all agree that echocardiography is the most important investigation tool which helps in diagnosing the heart failure. Not only the diagnosis part, but the prognostication and treatment could be based on the investigation, which is most important is echocardiography. But my concern is also in the hospitals, because we all are dealing most of the cardiac patients, and we are also doing echocardiography. Me, you, Dr. Grover, Dr. Rajesh, we are all having echocardiography machine. But sometimes at emergency, at night time, when we don't have access to echocardiography, and certain centers where we don't have echocardiography machine readily available, so in those cases, clinical diagnosis, their symptoms, as you told, JVP, and then the importance of markers, especially the pro-BNP, becomes much more important. But definitely we all agree that echocardiography is the investigation which not only helps in diagnosis, but prognostication is very important. And so moving to the other aspect, which is very, very important whenever we are prescribing our patients with MRAs, that is hyperkalemia. So Dr. Rajesh, what do you say? How much important is hyperkalemia whenever we are using MRAs, and up to what degree of renal impairment you are using MRAs in your patients of treating heart failure? You are mute, Dr. Rajesh, you are mute. Dr. Rajesh?
Hello, sir.
Yeah, please, you are mute.
Sir, are you listening me now?
Yeah, now the things are clear.
Initially, we measure the serum potassium levels. If serum potassium level is less than 4 and eGFR is more than 50 ml per minute surface area, then we start the MRAs. And if the most of the commonly used MRAs are spironolactone, epinephrine, and now the third generation phenylephrine is there. And if serum potassium level increases up to 5.5, then we have to stop the MRAs. And the GFR falls below 30 ml per minute surface area, then we have to stop the MRAs. This is the criteria used for using the MRA. So initial measurement of potassium is more important, and electrolytes are more important.
So this is the beautiful slide which tells us how we go ahead with the treatment of MRAs in our patient. So how we increase or decrease the dose of MRAs, because most of the time we are using either spironolactone or epinephrine. And the basic formula is spironolactone 25 milligram is almost equal to epinephrine 50 milligram. That is why if it is less than 40, you can very well go with the start of spironolactone 25 and epinephrine 50. And if it decreases, you need to reduce the dose to half. That means 25 milligram alternate day for spironolactone, or epinephrine you need to decrease from 50 milligram to 25 milligram. And if it is more than 6, you need to stop, evaluate whether really a spironolactone is the problem, or any other thing, ACE inhibitors, ARBs, or chronic renal disease. And if it is between 4 to 5.4, we need not to change the dose of MRAs. So that is the basic principle, how we follow our patients, what is the starting dose of MRAs. So these are the basic issues which we always try to look for whenever we are treating our patients of heart failure with MRAs. And that is the reason for patients, those who are having HFrEF, that is with reduced ejection fraction, MRAs has become the class 1 indication. And even in patients, those who are having moderately reduced ejection fraction, MRA is a class 2B indication that mostly we feel that these patients should be given MRAs. One concern is potassium. Second concern is creatinine. If creatinine is more than 2.5, we need to be very careful. And if it is less than 2.5, we can start our MRA patients. So these are the things which we need to look for. The other important agents other than MRAs are ACE inhibitors, ARNI, beta blockers, SGLT2 inhibitors. These are the 4 drugs which are class 1 indications in patients those who are having HFrEF. If patient is hypervolumic, in congestive heart failure, pulmonedema, then definitely you need to use loop diuretics. And in certain conditions, we need to go for the revascularization or mechanical devices. So in what percent of patients we use MRAs for heart failure patients? So Dr. Rajesh, how much percentage of the patients you are using MRAs for the treatment of heart failure?
In today practice, it is the first line drug. And in most of the patients, we are using the MRAs. As main action of MRAs is it doesn't alter the plasma osmolality, because it helps in reduces the sodium reabsorption along with water. So the plasma osmolality doesn't changes, and volume overload decreases. Both it decreases the preload and afterload. So MRAs are going to become the first line drugs along with the low dose beta blockers like carvedilol, bisoprolol, and ACE inhibitors.
Dr. Parminder, what do you say? Basically, MRA is the class 1 indication. So are you going to start all these 4 agents as SGLT2 inhibitors, beta blockers, ACE inhibitors, ARNI, MRAs, all 4 things all together? Or do you have some criteria how you go with the one particular agent over and above the other?
That Nitish is really a very easier said than done, because theoretically it's looking very beautiful, very glamorous. In fact, when you're actually pragmatically or really practically you're doing it on the patient, there are large and loaded with problems. Now, in fact, you have when you're choosing your patients, those who are actually post-MI, that too in first 40 years or 48 hours or somewhere around that. You actually look at the fluid sacs and all, if they are had a bit of a fusion or anything is there, or the patient is really ejection fraction, or it's a kind of LV dysfunction is there, LV systolic dysfunction is there. I think this is the ideal time to start with the inhibitor as well as the MRAs. Now, but exactly, now if you are in fact not having a very close watch on the urinary output and all, definitely all these things, they don't decompensate your patient very easily, very quick. And so you have to go one by one. You can't do it all the time with all these agents at one time. Now, in fact, if you go by that, now, will you choose the MRA for post-MI setting, or will you choose the ACE inhibitor? So exactly that is the situation at the time. I think most of the time, as we have been doing clinical practice, it is always the ACE inhibitor. That is, in fact, the first drug that needs to be given if you are having your patient post-MI and that too in heart failure. Now, but definitely, if your patient is tolerating well, ACE inhibitor, the next agent can be in quick succession. It can be the beta blocker or it can be the MRA. Now, at that time, I generally choose, it depends on the tachycardia, what are the heart rate the patient is having at that time. If the patient is tachycardic, definitely I'll go ahead with the beta blocker. But the patient is not much tachycardic at the time, patient is compensating, patient is coming up out of that situation, then if most of the time it is the MRA that I generally go ahead with. It's a kind of a clinical practice. But the more you do it on your patient, the more you learn and more you do that. And that is how that I generally buy my practice according to that. Is the most of the time is the ACE inhibitor in the post-MI setting. But if your patients are coming up in the clinical practice in the outpatient department, then good number, or you're admitting your patient with class 3 or somewhere around that, then definitely at the time, What I exactly do it on my patient, I look at the heart rate, look at other things, look at the pleural sacs, look at the urinary output, look at the well, all these things. They have to be taken care of. Now, then accordingly, when these so effective drugs, RD and all these things are available with you, the first agent to be started on those patients most of the time is RD. And at that time, if you find that your patient is tolerating RD, your patient is doing well with that, then definitely, as we know that ARPs and all like that, ACE inhibitors, all these drugs, they are actually having an access onto the aldosterone finally. So spironolactone and all that, that is being inhibited at particularly when you are having inhibition of that axis. No, MRA is definitely, it's not looking at that electrolyte scenario, or just it's basically fluid overload situation. These are the drugs which are antifibrotic. They are preventing apoptosis. They are in fact a lot of interstitial fibrosis which comes later on. That has to be stopped. With all these drugs, I think if you go one by one, it's RNA most of the time, then followed by that, it can be the MRA, and then accordingly the beta blocker or the other drugs available around. This is how generally I do it in my clinical practice.
Rightly said, Dr. Parminder. But the thing is, we have facing what is with aldosterone angiotensin excess escape phenomena. Once you start with ACE inhibitors or ARBs, after certain time, aldosterone levels start again rising. So that is the reason MRAs in due course of time you require to add on with ACE inhibitors or ARBs. So Dr. Grover, so how do you start your MRA patient, heart failure patients, MRAs over and above ACE inhibitors and beta blockers? Grover, please.
It was well told by Parminder also that each patient has to be individualized. Actually, every patient has to be evaluated whether he is post MI or he is in heart failure due to dilated cardiomyopathy, or he is in stable condition or unstable condition. Because if patient is edematous, is having a lot of fluids, we have to start with diuretics first and decongest the patient, and then evaluate. If patient is having severe tachycardia, beta blockers should be the first line. And once the patient gets stabilized, then I usually put them on, think of putting them on MRAs. Before that, I try to control with diuretics, beta blockers, and if needed, the ACE inhibitors only. So and because of the risk of hypotension, because of the risk of hyperkalemia, these things should be watched, and stage by stage we should add on the drugs. Though it looks very, very attractive once you see the scenario of these drugs, the effect of these drugs, you feel like putting your heart failure patients all the groups of drugs, but usually patient can get controlled with simpler drugs also. And particularly now, SGLT2 inhibitors are there in the market. I try to put them at the earliest, whenever patient is fit, because there is a clinical and research document also to show that these are the drugs which are really preventing death, and which are the most proven drugs for heart failure, and they prolong life, they prolong sudden death. So whenever at the earliest, I try to put the patient on SGLT2 inhibitors, and it has given me good results. But of course, I will repeat that each patient has to be individualized rather than making a direct formula. But we have all the options available to us now. To manage heart failure nowadays looks little easier than about 10 years back, when apart from diuretics there was nothing. But now we have so many options, and we should treat accordingly. But depending upon the clinical picture of the particular patient.
Yeah, definitely, you are absolutely right that each and every patient should be individualized. But there are certain things which we need to take care is, because you are rightly saying that SGLT2 inhibitors are one of the earliest agent to start with, because it is recommended that these are the agent which are least hypotensive. Because most of our patients, those who are not hypertensive, sometimes the main problem or limiting factor is blood pressure. If blood pressure allows us, we can start all the four agents, right? away, because ACE inhibitors, beta blockers, MRAs, but there are certain limitations why we are not able to start all four agents. So in those conditions, when blood pressure is borderline, SGLT2 inhibitors become the first choice. As Dr. Parminder was saying, that absolutely, if post MI patient, if we need to start ACE inhibitors or beta blockers, because beta blockers ischemic heart disease, we are having a compelling indications for beta blockers. If they are not in congestive heart failure, wet, beta blockers and ACE inhibitors, these are the two agents which should be started at earliest. And in due course of time, ACE inhibitors after 4 weeks or 6 weeks of myocardial infarction should be replaced by RD, because that is the agent which is most helpful. So after 6 weeks, you should replace ACE inhibitors with RD. And because after some time, these ACE inhibitors are not able to reduce the aldosterone level, which is going to affect adversely on myocytes, leading to fibrosis and inflammation. That is the reason MRAs needs to be admitted once added once you are having a stable patients on ACE inhibitors and RD. So for improving, you want to say something?
No, absolutely right. You are saying.
So when do you prefer using eplerenone or spironolactone? Dr. Rajesh, what is your say on this?
Eplerenone is the first line drug. If we consider eplerenone and spironolactone, eplerenone is the choice drug, as it has less chances of hyperkalemia and less chances of hypotension. So eplerenone is, I think, the best line.
Dr. Parminder, what is your say on this?
Definitely, it depends on the situation, although the efficacy of the two drugs is not comparable. But definitely, I think, given the scenario of gynecomastia, or you're dealing with a male, or patients are already on, if they are on digoxin, diuretic, so many other things, and sometimes they do have this problem of gynecomastia, or sometimes the patients they do have because of the ACE inhibitor, but not with the RD, that we are encountering more of hyperkalemia that is really lesser as compared to the previously available ACE inhibitors or ARBs. Now, this hyperkalemia problem is much less now. I think ARBs, if you are straight away giving your patient ACE inhibitor or ARBs, I think the better drug would be eplerenone. But if you're dealing with a female or a female patient or something like that, efficacy is not much of a problem. Or hypertension, as we all know, that is better controlled with a spironolactone rather than eplerenone is not that effective when once the patient is hypertensive and with heart failure and all. So I think all these different manifestations are there, but different presentations are there. Accordingly, the drug has to be chosen. But larger said than done, that in fact, eplerenone has got a much better acceptability now, as we have been dealing with the patient, and the patients, they do respond to this drug equally well as we had been doing practice with the aldosterone antagonists like that, spironolactone that we have been using. But I think the problem of dyslipidemia and other things definitely are on a lesser scale with the eplerenone. So that can be a drug depending on what exactly the type of the different drugs that you're using in particular patient, that you can take accordingly. Do a kind of a practice where your patient has to visit your clinic not repeatedly, not frequently, or not having developing electrocardiographic abnormalities or something only because of hyperkalemia, and definitely it becomes very unwelcome to have your patient repeatedly admitted in your hospital. And if that problem is minimized with eplerenone, anybody will welcome that. And this is how that drug has got wider acceptability.
So we all know that among the two MRAs, spironolactone has edge only on cost factor. But eplerenone is definitely in compliance form, less of gynecomastia, less of dyslipidemia. Eplerenone has edge over the spironolactone. but definitely cost is sometimes an issue
Yeah,
when we are
that's
treating our patients. So that is
that's
the only thing where we can have use spironolactone in favor of eplenon. Otherwise, eplenon stands better than spironolactone. So we are using the different doses of spironolactone and eplenon, as we discussed that 25 milligram of spironolactone is equal to almost, if we go by the potency wise, is equal to eplenon of 50 milligram. But the issue of hyperkalemia, so does it really a major issue with MRAs? We have the trial in which it was seen that the meta-analysis, only 9.3% of patients of treating those who are on MRAs were having hyperkalemia problem. So almost 90% of the patients, they don't encounter hyperkalemia. And among those, only half were having hyperkalemia because of MRAs. So MRAs are not leading to hyperkalemia in almost 95% of the heart failure patients whenever you are using MRAs. So that is a major myth which needs to be clarified to all of us, that MRAs causes hyperkalemia, but only in 5% of the congestive heart failure patients whenever we are using this particular agent. So what percentage of heart failure patients MRA develop hyperkalemia? And
9.3%.
please?
9.3%.
So 9.3% they are having hyperkalemia, but half of them, they are not because of MRAs. So that means 95% of the time we don't blame MRAs for hyperkalemia in patients those who are being treated for it.
Dr. Nitish, but the point is, if you really adopt a kind of a safe practice, most of the time we are interested for that our patient don't come up with a complication and they have a better a kind of a complication free or event free situation back home. And if the drug is available, and when the multiple drugs are there on ACE inhibitors, aldosterone, and all these drugs are given to the patient, then definitely the chances of hyperkalemia slightly become better, become more. And if you have got a better drug available, definitely which is having lesser problem on that front, that if it is given, I think that gives you a kind of a safety, more safety to your patients. And most of the patients, they avoid coming up only because of all these events or complication, which make them have to have come. And most of the time, when the patient become hyperkalemic, they don't have this simply hyperkalemia. They have other problems, the elevated creatinine, the electrocardiographic abnormalities, the heart blocks, all these things come up. Most of the time, the patients land up with the AV blocks and all like that. And that becomes a very, and the moment you investigate, you find if you are not really monitoring your patients well, and that really becomes a little difficult. There is a kind of.
But Parminder, I think efficacy is an issue with the eplenon. It is not that efficacious as the other drugs available with us. It can, I consider it to be put on the patients who I suspecting that they won't come for the follow-up. Otherwise, efficacy-wise, if you say Dr. Garg will be able to tell better, I consider it at a lower scale than as compared to the other drugs available. What do you say?
The efficacy for, in fact, if the patient is hypertensive, definitely the aldosterone, that is, in fact, hello.
Yeah, Dr. Parminder, I would say that potency wise, if you say spironolactone 25 milligram is equal to eplenon of 50 milligram.
Yeah,
that is there. Yeah, but as compared to other drugs like receptor blockers or the SGLT2 receptors and other drugs available for congestive heart failure, this is lower in the list. But this is what I feel. I don't know. You can tell me better.
The thing is, you individualize the treatment. SGLT2 inhibitors are definitely indicated those who are having low blood pressure, because SGLT2 inhibitors are they are least hypotensive effect. But sometimes when you are already having your patients or ACE inhibitor, ARNI, and aldosterone angiotensin excess is again becomes a escape phenomena, then MRAs needs to be admitted,
Yeah,
added to this
that is
patient.
there,
Yeah.
but not as a first line treatment. It is an add-on therapy. It is good, but it can't be used as a first line. This is
So
what I
how do
feel.
you manage your hyperkalemic patients, Dr. Rajesh? What is your say on this?
Uh, First of all, treatment for hyperkalemia is intravenous calcium gluconate. Then we give insulin plus glucose, 5% dextrose. Then loop diuretics. Then we can give the sodium polystyrene. That is by oral route, around about 50 gram in 30 ml of sorbitol. Or we can give per rectum also sodium polystyrene. This is the way we can manage the patient with hyperkalemia.
Sodium bicarbonate, soda bicarb is also one
Soda
of the things
bicarb
which,
also.
yeah, and definitely you need to stop MRAs, you need
Yeah,
to
that
stop
is
ACE
that.
inhibitors, you need to evaluate these patients, especially
That,
for renal failure, because
that is
these
very important.
sometimes these patients becomes renal failure in due course of time. So you need to be very judicious whenever you are evaluating our patients. So the time of start again becomes very important, and in the EFSTAS trial we have seen the patients those who were started with MRAs within 7 days of left ventricle dysfunction, they did fairly better in comparison to those patients those in which MRAs were started more than 7 days, and 34% reduction in sudden cardiac death in patients those who were started early. So if you start early, you get better benefits of eplenon, and that is well documented in EFSAS trial. So in clinical practice, how early MRA is initiated in our management of heart failure patients, we have already discussed. These are the different agents which we are using in treating our patients for heart failure: ACE inhibitors, ARBs, ARNI, beta blockers, SGLT2 inhibitors, and if there is fluid retention, loop diuretics. There are other certain measures like if somebody is having ischemia, revascularization is one of the important factors to reverse left ventricular dysfunction, and certain devices like CRTP, CRTD also. And if patient is not improved with all the measures, pharmacological agent, mechanical agents, then definitely heart transplant, which has become a reality nowadays in India and in many centers. It is actively programmed to transplant the heart. Definitely, the donor is again a limiting factor, but it has become a reality, and we have seen that these patients' survival benefits are very well seen over 6 months to 1 year. So, what is the preferred choice of therapy? Eplenon alone, eplenon plus torsemide, spironolactone, or spironolactone plus torsemide. So these are the different uh, um, diuretic combinations. So Dr. Parminder, what is your say on this? Which agent you start with among all four?
Yeah, as we have already discussed, now it in fact initially that the diuretics you can't go away from that. Really, you have to unload your patient of all that excessively. So definitely, this is the one thing that will be considered the most if your patient is having all that kind of fluid excess you find in different areas of the body. Now, the other thing is the urinary output that has to be considered. And if you have not done well on diuretics, you straightway go ahead with the ACE inhibitors, you straightway go ahead with the MRAs. Definitely, you will get a kind of negative all that in the coming of days. So I think starting on with the diuretics and the ARNI, and then depending on that, the MRAs, if it is a kind of a situation that is there in the outpatient department, and if you are giving definitely a patient in the ICU, as we have already discussed, it's most of the times ACE inhibitor as well as MRA that can be given in the first 24 to 48 hours. That always your patient do well. but you have to keep a watch, very close watch. You have to keep on monitoring your patient on for all that renal abnormality that may come up. And you have to really stop all these agents at the time. And particularly, you have to buy more time and start with the lesser dose of the ACE inhibitor or ARBs, and thereafter, waiting for some time, you go ahead with the MRAs and all like that. I think that this is all that you have to individualize a particular situation that you are dealing with, and these agents. As most of the time this is understood that simply possibly are taking care of the fluid load or fluid overload. Exactly, this is not. They are really having a better on mortality, better on morbidity. All these events, they are prevented far better. The quality of life, the longevity, all these things, survival, that all becomes better only because the drug is acting at the cellular level, preventing the apoptosis, preventing the interstitial fibrosis, as preventing that cell death, which is happening in the myocardium. And so once these drugs are not given to the patient, definitely your patient will not live for a longer time. They definitely will have more problem. And all these things, like hyperkalemia, renal abnormality, they can be dealt with very, very effectively if you are monitoring your patients well. There hardly is not of really that huge or that of big a concern, because once you monitor your patient well, you pick up your patient at the right time. You have to choose between a little bit of rise of creatinine or it is too much rise of creatinine. The patient has become symptomatic of the exactly the reverse situation. Because of the renal dysfunction, the patient has become overloaded. Now, at that time, you have to take a decision that which agent you are going to withdraw, either ACE inhibitor or the MRA or both. So that is how that one really, and with the furosemide or the torsemide is a little bit potassium sparing. You have to take care of that. If your patient is on digoxin, and you can combine it with the furosemide with aldosterone, because aldosterone will give you a slightly potassium onto the safer zone, and you can combine it with the furosemide and digoxin. That is how that you can keep your patients. Some of the patients, they are not tolerating ACE inhibitors, ARBs, and all like that. If this triple drug, digoxin, furosemide, and the aldosterone, if that is given, the patient don't develop resorption-related complication coming up because of the hypokalemia and all like that. So that is how, in fact, in the clinical practice, you are combining, you are doing it on these agents. But one thing one must not forget, that these are very important drugs. Most of the time, these drugs used to come in combination with the diuretics, and people were giving it as simply diuretic, just to decongest the patient. But that is not. In fact, torsemide or furosemide, they may be unloading your patient, but aldosterone is simply not to be bracketed with a torsemide or furosemide, because that is a drug that has helped to have your patient a better survival, lesser morbidity, lesser mortality. And this has been shown in a good number of trials. So if you are not giving this drug to your patient, definitely you are missing something on the management side.
So very aptly described. So Dr. Rajesh, what is the other indications which you are using MRAs for other than heart failure?
MRAs can be used in hypertension, but not so effective, but can be used in MRA. One thing strange is angiotensin 2 receptors in lungs binds the coronavirus and increases the severe respiratory syndromes. Now my question is whether MRAs are helpful in that.
Dr. Grover, what do you say? Whether you are using MRAs in treating your COVID patients?
Sorry.
Dr. Grover.
Not because of COVID, because if a COVID patient has some other problem, cardiac problem, only then I think primarily these are not the drugs for COVID. But if COVID has produced heart failure or some cardiac problem, then it should be thought. But otherwise, I am using MRAs in resistant ascites due to other reasons also, like cirrhosis or so. If you add on to diuretics, it gives very good effect. That is the only indication. COVID as such, it is I don't think it is a very use unless patient has cardiac complications.
In
So,
cirrhosis,
indication
definitely MRAs
of
are the drug of choice.
Yeah,
If
definitely
diabetic.
the ascites and all like that. The patient
ascites,
is having a lot of
nephrotic syndrome, and cirrhosis, nephrotic syndrome, hypertension,
Yeah.
ascites.
Yeah.
So what scientific initiative you would like to suggest CIPLA for increasing awareness among the physicians? So, Dr. Grover, Dr. Parminder, what is your take on all this?
They should make these drugs affordable. That is
Yeah.
the one suggestion, because people usually live in life. This drug has to be taken for a long time, so these drugs should be affordable. And
For physicians, what
physicians
what should they do that these physicians should write more of MRAs to treating for patient for heart failure? You are mute, Dr. Grover.
drugs are not that commonly used because of lack of awareness. So the companies should produce awareness, do more of CMEs to educate the people and educate the doctors for using these drugs in more and more indications. And only then the benefit can reach to the patients.
I think we have discussed quite exhaustively about the MRAs. So, Kulwant and
Colonel, sir,
Colonel,
Colonel, sir, Colonel.
Colonel, yeah,
Yes.
Colonel. So, I think we have. What is your say, and how do you help our patients to have more compliance? And how do you suggest the other initiative which CIPLA is taking to make more awareness regarding the CPs? So, what is your say, and what are the different other indications you are prescribing MRAs for?
Sir, first of all, sir, thank you, sir, for giving such a nice presentation. Sir, as per company's criteria, sir, we are doing regularly promoting to physician level also, sir, because as per the recent latest updated guidelines from ACC and HFSA, it is recommended that, sir, MRA therapy should be used as a first line treatment in heart failure when the patient comes to the hospital after any cardiac arrest. So, in this four pillars, that is of MRA, then ACE inhibitors, then ARNI, and SGLT2. We should be given first line therapy as a MRA, sir. So we are now promoting this to each and every physician, cardiac physician who is practicing as a cardiologist, apart from cardiology. So these are the main focus, sir. So we are now rightly focusing on Ditor E to the physician level also, sir, in a mass promotion.
So other than heart failure, where you are saying that
Sir, in gynecomastia, sir, we are also promoting, sir, and rest I
that
think
is for in replacement of spironolactone, but
yes, sir, yes.
and dyselectrolytemia, when there is so much of dyselectrolytemia, you prefer epinone in comparison to spironolactone.
Okay,
So,
sir. Okay, sir.
I think we are quite right at time, though we are already sitting around 10 minutes. We were
Yes, sir,
late
yes, sir.
also. So,
Yes, sir, yes, sir.
so if we other panelists they agree, then we can conclude the session.
Definitely,
yes.
So
definitely.
we had a very good time discussing MRAs and congestive heart failure. Thank you, Dr. Parminder, Dr. Grover, Dr. Rajesh. We really missed you, Dr. Sondi. Right now you are online?
Sir, actually they are in, sir, some procedure, sir. Actually, they just call us that I'm not able to speak because due to emergency. So
okay,
that is why, sir.
both Dr. Vikas Deep and Dr. Sondi.
And yeah, sir. I have talked with them, sir.
One compliment, Dr. Nitish. You are an excellent teacher, so you explain the things well.
Or it's so nice of you, sir.
You are very good in explaining the things. I will say you're an excellent teacher.
I will agree with Dr. Grover that Dr. Nitish has organized the things well.
Thank you very much.
All blessings from Dr. Grover and Dr. Parminder. You are senior and guiding force for me. And a very good friend, Dr. Rajesh, who is treating very well our patients, those who are not only the cardiac one, he is one of the most innovative and I say that multi-talented face. He treat gastroenterology patients very well, cardiac patients. So very good friend, Dr. Rajesh, and guiding force, Dr. Parminder, Dr. Grover. Thank you very much.
Thank you.
Thanks for your blessing.
Thank you so much.
Bye bye
Bye.
everybody.
Bye.
And then we are concluding right now.
Yes, sir. Yes, sir. Thank you, sir. Thank you.
Okay. Bye bye.